Dear doctors, dear colleagues, welcome to our seminar today about the lung cancer. This will be presented by me, Sara, Ahmed, and my colleagues Zainab, Firas, Sidra, Suhib, and Sumaya Thakwan, and the supervisor is Dr. Elaf. Generally speaking, the lung cancer could be primary, arising from the lung, or secondary, arising from other organ reaching the lung. It is a common disease. In fact, it is the most important cause of cancer-related death, accounting for about one-third of cancer death in men, and has become the leading cause of cancer death in women as well in industrialized countries. The incidence in women continue to increase due to smoking habit, with more women dying each year from lung cancer than from breast cancers since 1987, according to American Cancer Society estimates. Although cessation of smoking decreases the risk for developing lung cancer over time, it never returns to baseline levels. Now, what about the pathogenesis and the risk factor of lung cancer? Lung cancer, like any other cancer, it arises from accumulation of mutation. In the early stage, there will be suppression in the tumor suppressor genes located on the short arm of chromosome 3. Later on, there will be mutation in the TP53 suppressor gene and the KRAS oncogene. A subset of adenocarcinoma, about 10% in white and 30% in Asian, particularly those arising in non-smoking women, have a mutation in the epidermal growth factor receptor. In case of squamous cell carcinoma, when the respiratory epithelium exposes to irritant, there will be squamous metaplasia. Later on, there will be dysplastic changes of the cells. Continuing exposure to irritant, there will be carcinoma in situ. And finally, this will lead to the invasive squamous cell carcinoma. And now, to have more clear idea about this subject, please give me your attention to the following presentation. Lung cancer can start in the windpipe, the main airway, or in the lung. It develops when uncontrolled growth of abnormal cells inside one or both lungs. These cells grow, forming a tumor. More than 90% of lung cancer in the UK are caused by smoking. If you are a smoker, quitting is the best thing you can do for your health. Passive smoking also increases the risk of lung cancer. Lung cancer is more common in older people and people with chest problem or lung diseases such as emphysema. Other risk factors, including exposure to radon gas, air pollution, and chemicals. Now my colleague Zainab will continue with us about the signs and the symptoms of the lung cancer and the paraneoplastic syndrome.
Alaikum, I am Zainab Firas. I will continue with signs and symptoms of lung cancer. The patient come to hospital suffer from chronic coughing, hemoptysis, wheezing sound, chest and bone pain, chest infection, difficulty swallowing, hoarse voice, shortness of breath, unexplained weight loss, and nail clipping. About 3 to 10% of those having lung cancer will develop into paraneoplastic syndrome. What we mean here by paraneoplastic syndrome? We mean this lung cancer will begin to secrete hormone such as parathyroid hormone, which is normally secreted from parathyroid gland and resulting in hypercalcemia. This occurs especially in squamous cell carcinoma. Second is releasing of adrenocorticotropic hormone and resulting in Cushing's syndrome. 3 is antidiuretic hormone secretion and resulting in syndrome inappropriate antidiuretic hormone. 4. Neuromuscular syndrome and resulting in myasthenia gravis. This occurs especially in small cell lung cancer. 5. Clumping of the finger. 6. Coagulation abnormality, which occur mainly in adenocarcinoma. After all these signs and symptoms, the physician sent the patient to do some investigation to give a clue about the type of the lung cancer. First is chest X-ray. Second, sputum cytology, which may reveal malignant cells which show hyperchromatism, pleomorphism, increase in C ratio, and abnormal mitosis. 3 is CT scan, is helpful for localization and metastatic spread of the tumor. Here we see this is the chest X-ray and this is CT scan, which is helpful in the diagnosis of the lung cancer. 4 is positron emission tomography, is performed to detect metabolically active tumor metastasis. 5 is biopsy. 6. MRI of the brain, liver ultrasound, and bone marrow biopsy, which is important in the metastasis of the cancer. And other important assessment including pulmonary function test, full blood count, and biochemical profile. The most important investigation in the pathology is biopsy, either percutaneous or bronchoscopic biopsy. As we see in the picture, this is thin tube will pass either through nose or throat to the airway. This will make to take this biopsy and send to microscopic examination to see either small cell lung cancer or non-small cell lung cancer. Small cell lung cancer is more aggressive, while non-small cell lung cancer is more common. Non-small cell lung cancer will either divided into adenocarcinoma or squamous cell carcinoma, large cell carcinoma, and many other. Here we see histological classification of malignant epithelial lung tumor. This is WHO classification in 2015 into adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and other mixed carcinoma. And now my colleague Sumaya will continue.
After I took the biopsy, I will look about the types of the lung cancer depending on the gross and the microscopic feature of the biopsy. First, I have the adenocarcinoma. Adenocarcinoma are usually peripherally located, but also may occur close to the hilum. In general, adenocarcinoma grow slowly and form smaller masses than do the other subtypes, but they tend to metastasis. Here we have the peripherally located adenocarcinoma. Microscopically, the adenocarcinoma usually assume a variety of growth patterns, include acinar, gland-forming, papillary, mucinous, which is often multifocal and may manifest as a pneumonia-like consolidation, and solid types. The second type of the lung cancer is the squamous cell carcinoma. Squamous cell carcinoma are more common in men than in women and are closely correlated with a smoking history. They tend to arise centrally in major bronchi and eventually separate to local hillier nodes, but they disseminate outside the thorax later than do other histological types. Large lesions may undergo central necrosis, giving rise to the cavitation. Here we can see the pearl shape of the squamous cell carcinoma. Microscopically, the squamous cell carcinoma usually preceded by the development over years of squamous metaplasia or dysplasia in the bronchial epithelium, which then transform to carcinoma in situ. Atypical cells may be identified in cytological smear of sputum or in the bronchial lavage fluid. Here is the normal epithelium of the lung that undergo the exposure to irritation, and the metaplasia or dysplasia will occur. Then this dysplasia can be seen as a loss of nuclear polarity, nuclear hyperchromatism, pleomorphism, and mitotic figure. Then the carcinoma in situ will develop, and once the invasion to the underlying mucosa occur, the squamous cell carcinoma can be easily seen. The third type of the lung cancer is the small cell lung carcinoma. Small cell lung carcinoma generally appear as pale gray, centrally located masses that extend into the lung parenchyma. The small cell lung carcinoma microscopically usually appear as a relatively small tumor cell with a round to fusiform shape, scant cytoplasm, and finally granular chromatin with a salt and pepper appearance. Numerous mitotic figures are present. Here we can see the necrosis, and also we can see the fragile cell that lead to the development of the crash artifact during the preparation, and also we can see the small round fusiform shaped cell with a scant cytoplasm and granular chromatin with a salt and pepper appearance. The last type of the lung cancer is the large cell carcinoma. They are undifferentiated malignant epithelial tumor that lack the cytological feature of the neuroendocrine carcinoma and show no evidence of glandular or squamous differentiation. The cell typically have large nuclei, prominent nucleoli, and a moderate amount of cytoplasm. This can be seen here. We can see that there are large nuclei, prominent nucleoli, and also a moderate amount of cytoplasm. After I knew the type of the lung cancer, now I want to know if the cancer had spread or not, depending on the TNM staging system. Stage 1 tumor size is less than 3 cm and there is no lymph node involved. M0 means that there is no metastasis. Stage 2 tumor size is about 3 to 7 cm. Invasion to the visceral pleura, main bronchus. The lymph node involved is the ipsilateral bronchopulmonary lymph node. M1 means that there is metastasis bilaterally, distant metastasis, and also a malignant pleural effusion. Stage 3 tumor size is more than 7 cm. Invasion to the phrenic nerve, diaphragm, chest wall, and main bronchus. The lymph node involved is the ipsilateral mediastinal lymph node, and about the stage 4, the invasion to the mediastinal organ, vertebral body, and tumor nodule in different ipsilateral loop can be seen. The lymph node involved is the contralateral mediastinal, and supraclavicular lymph node would have the metastasis. Now my colleague Sidra will talk about the metastasis.
Hi, my name is Sidra Suhib, and now I will talk about the metastasis of lung cancer. It means when the cancer breaks from the lung and spread to the other place of the body and can transmit through the blood and lymph and affect the brain, spine, liver, or adrenal gland. The feature of metastasis: lung cancer tend to spread to the lymph node. Second, extend into pleural and pericardial cavity. They may compress or infiltrate the superior vena cava. A typical neoplasm may invade the brachial or cervical sympathetic plexus, causing Horner syndrome. Horner syndrome is a combination of signs and symptoms caused by disruption of the nerve pathway from the brain to the face and eye on one side of the body. What are the common symptoms of the Horner syndrome? First, loss of sweating on the face. Second, partially dropping upper eyelid. Third, small pupil. And atypical neoplasm are sometimes causing a Pancoast tumor. A Pancoast tumor is a tumor of the pulmonary apex. It is a type of lung cancer defined primarily by its situation on the top end of either the right or left lung. Pancoast tumor is often combination by disruption of the first and second rib and sometimes the thoracic vertebrae. At diagnosis, more than 50% of patients already have distant metastasis, while an additional 1/4 have disease in the regional lymph node. The prognosis remains dismal. The 5-year survival rate for all stages of lung cancer combined is about 16%, a figure that has not changed much over the last 35 years. Even with disease location to the lung, the 5-year survival rate is only 45%. Now we will talk about the secondary lung cancer. As we see clearly in this picture, it will be variable in size and firm whitish gray nodule of metastatic carcinoma. Hilar lymph node show carbon particle. And now we will talk briefly about the treatment. First, surgery. Remove of the cancer affected part of the lung. Second, radiation. Use high power energy beam from the X-ray and proton to kill the cancer cell. Third, chemotherapy. Has a drug to kill the cancer cell. And immunotherapy. Use your immune system to fight cancer. And finally, the palliative care, specialized medical care focus on providing relief from symptoms and stress of the cancer. And thank you.